This is a 57-year-old man with a left-sided colon cancer. He underwent a laparoscopic colectomy and was found to have stage 3B disease. He had 5 out of 20 lymph nodes involved. The tumor had a KRAS mutation and was microsatellite stable. He underwent treatment with 12 cycles of FOLFOX, although the oxaliplatin was held in the last 2 cycles because of the development of neuropathy. Unfortunately, 6 months later, he was found to have multiple hepatic metastasis and was started on therapy with FOLFIRI plus bevacizumab. When I see a patient with stage 3B disease, I ask them how much detail they want to know about their prognosis. For people who want some precision, we'll often go to one of the online calculators where we can input data that will tell us what their risk of recurrence would be without any therapy, what their risk of recurrence would be if they just had fluorouracil, and what if they have FOLFOX. In general, for a patient with stage 3B disease, the 5-year recurrence-free survival is about 50%. Now, if a patient takes chemotherapy with FOLFOX, that improves to almost 75%. For a patient with stage 3B disease, I emphasize that the highest risk of recurrence is in the first 2 to 4 years. However, we'll certainly follow them for at least 5 years. We explain there are ASCO guidelines and NCCN guidelines, which have a lot of similarity to each other. Essentially, if the patient is a candidate for resection for metastatic disease, for example, we'll certainly take the most aggressive course. That would involve seeing a patient every 3 months for a physical exam and a CEA level, at least in the first 3 years, and then imaging at least once a year, if not twice a year, and that would typically consist of a chest, abdomen, and pelvic CT scan. We also recommend a surveillance colonoscopy about 1 year after their original diagnosis. Subsequent colonoscopies can be performed based on the findings of that follow-up colonoscopy. Certainly every 5 years, some patients may require them every 3 years.